Hello, everyone, and welcome to today's webinar in the Public Health Webinar Series on Blood Disorders. This webinar is presented by the Division of Blood Disorders at the U.S. Centers for Disease Control and Prevention, which we all know and love as the CDC. I'm Dr. Catherine Hassel, and I direct the Hemoglobinopathies Newborn Screening Follow-Up Program for Colorado and Wyoming, and I also direct the Colorado Sickle Cell Treatment Center and Research Center at the University of Colorado, and have cared for adults living with sickle cell disease for a long time now. I'm delighted to be with you today to moderate today's webinar, where we will explore the important topic of newborn screening for thalassemia in the United States. Before I introduce our guest presenters, I'd like to go over a few points for joining this webinar, although congratulations on your success to get this far. On joining the webinar, you'll see two audio options. You can opt to listen via the speakers on your laptop or by using your phone to call in. If the phone option is chosen, the webinar toolbar will provide you with the phone number, the access number, and the audio pin that you'll need to join in that way. All audio will be muted. At the end of the presentation, we'll take as many questions as we can. And so to submit a written question, please use the question option in the area of your toolbar. The presenters will respond to as many questions as we can get in for the time allowed. Today's webinar will last approximately 1 hour and it will be recorded. We want to begin today's webinar with two brief audience polls. First, we're interested in knowing more about you, so please select your answer to this poll. We're interested to see who's listening in today and be able to tailor our presentation and answers to questions. So please take a moment and indicate who you represent, where your passion lies in the realm of healthcare. And we're going to give plenty of time for people to find their mouse and be able to click and make their system work. Technology, as familiar as we are with it, sometimes takes a moment to become more familiar with perhaps a new platform for you. All right, and so we have a really nice mix today between public health officials and healthcare providers. Congratulations and welcome to those individuals representing those with thalassemia or family members, our community-based organizations, and even our industry partners. Thank you very much for joining today. We'll have a second question for you, which we'll post. So we're interested about where you're joining us from. And it'll be really cool if someone checks each of these categories, but it might not be true and it's okay. But the virtual world really allows such a breadth of communication and opportunities and perspectives to be brought to this topic. So please take a moment and let us know from where you're hailing so that we again can have a perspective as we work through the material today and answer the questions. Be very interesting to see. All right, so mostly North America, often the case. Welcome to our colleagues to the East in Asia and or Africa, our European colleagues, and even from down under. Welcome to each of you, and thank you so much for taking time out of your day or night or whatever time zone you're in. All right, well, now it's my pleasure to introduce our first presenter, Dr. Michael Bender. Bender, as we all know him, directs a program for people impacted by hemoglobinopathies at the Odessa Brown Children's Clinic. It's a community clinic associated with the Seattle Children's Hospital. He also consults for the Washington Newborn Screening Program and has a research lab at the Fred Hutchinson Cancer Research Center. Bender received his American Society of Hematology Advocacy Award, was a member of the NIH Sickle Cell Disease Advisory Committee, is an active member of the Association of Public Health Laboratories Hemoglobinopathy Work Group, worked with the Puget Sound Blood Center's Rare Blood Groups program to increase the number of minority donors by overcoming cultural barriers and improving education and information services, and oversees the Northwest Sickle Cell Collaborative. I'd also like to introduce our second presenter who will follow Bender, and that's Patrick Hopkins. Patrick is the former chief of the Missouri State Newborn Screening Laboratory and has worked for the Missouri State Public Health Laboratory for over 38 years. He's made many contributions over the years with implementation of newborn screening disorders and new testing algorithms in Missouri, and really has contributed greatly to newborn screening emergency preparedness across the Heartland states. Patrick continues to work in the Missouri Newborn Screening Lab as a project specialist. He's leading the Missouri's Peer Network Resource Center, made possible by APHL and New Steps, to assist other state programs with their implementation and efforts for new disorders. Patrick also chairs the Association of Public Health Laboratories' new hemoglobinopathy work group and serves as a contracted consultant with APHL to provide technical assistance to state newborn screening programs as needed. So with that introduction, let's begin. Bender, take us away.
Well, thanks everybody for being here, and thanks to the CDC and Cooley's Anemia Foundation for making this happen. So newborn screening for thalassemia in the United States may not be the flashiest of topics, but there's a lot of confusion around it and a lot of variation, and we hope to sort some of that out. So the situation is that all states in the United States intend to screen for sickle cell disease by newborn screening. And the testing technology is fantastic, but it picks up unintended disorders such as severe thalassemias. So it's up to each program then to decide for itself how to address these thalassemia results. So I'm going to give some background about why this might be important. Patrick's going to go and talk about how newborn screening is accomplished, and then I'm going to come back and talk more about what you need to know. And the bottom line is most states test for thalassemias, but there's huge variation in practices leading to health inequities and variations. So why test for thalassemia in the newborn period? Thalassemia mutations are incredibly common. It's the most common monogenic disorder worldwide. Most of these people have traits and not severe disease, but it affects 5% worldwide. It's linked to protection from malaria. It's most prevalent, you can see in the map in Southeast Asia, the Mediterranean, Africa, and other places. But notably in the United States, we don't have strong incidence, prevalence, or location data for thalassemias. So it's common and it can be life-threatening. Clinically, it's highly variable, but some infants are transfusion dependent at a few months of age, and it can lead to severe end organ damage, growth delays, neurocognitive deficits if not treated. So it's severe, but it's also picked up by newborn screening for sickle cell. Not only is it picked up, but then there's treatments, and the morbidity and mortality in severe cases of thalassemias correlates with early transfusion and iron chelation and monitoring. Plus, now there's cures with stem cell transplant, gene therapy, and now even in utero transplantation. And then there's the genetic counseling implications, which are huge. And then there's the family perspective that if not diagnosed at birth, often infants are misdiagnosed as having iron deficiency. They're treated with iron. There can be delays in diagnosis, multiple referrals back and forth before a definitive diagnosis is made. So let's talk about hemoglobins. Hemoglobins carry oxygen. It's made up of 2 alpha type chains and 2 beta chains. And it's really critical that the number of alpha and beta chains is the same. There are qualitative disorders of hemoglobin where you make a normal amount of hemoglobin, but there's an abnormality in it, such as sickle cell. In thalassemia, it's a quantitative disorder. If you make hemoglobins, they can be normal, but in alpha thalassemia, you have more beta chains than alpha chains, and in beta thal, the opposite. I think most people are aware that you express different hemoglobins at different stages of development, that in the fetal period, you make alpha globin and you make gamma globin, and putting them together, you get fetal hemoglobin, or HbF. The amount of gamma falls as you approach birth and further after birth. Meanwhile, beta increases steadily, and in children and adults, you still have alpha, but then you have mostly beta, and that forms hemoglobin A. So what happens for people that don't have thalassemias? Well, the alpha genes, you've got 4 alpha genes, they make alpha globin. In the fetal period, you make gamma, and roughly the same amount of the two, and you get fetal hemoglobin. You make a little bit of beta, but you have a lot more fetal hemoglobin than hemoglobin A. Later on in life, you make mostly beta chains, and you get mostly hemoglobin A. And so there's a lot more A than F. So understanding what happens to any unpaired chains then explains how newborn screening is done, which Patrick will go over, the pathophysiology that leads to clinical problems, and why screening for alpha thalassemia is so much easier in the newborn period. So in alpha thal, most commonly mutations causing it are deletions, and I'm not going to be able to talk about non-deletion forms. But when you have deletions, you don't have as many alpha chains. So in the fetal periods, you have less alpha than gamma, so you make some fetal hemoglobin, but those leftover gamma chains form tetramers, hemoglobin BARTs, which unfortunately are not good at carrying oxygen. It's this presence of BARTs in the newborn period that's a marker of alpha thalassemia and makes it a really easy screen. In the adult, instead of gamma, you mostly have beta. Unchained beta chains are not stable. They disappear. It forms hemoglobin H. And so it's much harder. You can't use it to screen adults. For beta thalassemia, there's a lot more variation in the type of mutations that cause beta thalassemias. And for this presentation, I'm not going to talk about things that affect gamma. So here, if just beta is impacted, in the fetal period, you make alpha, you make normal amounts of gamma, you make normal fetal hemoglobin, everything's normal. But then as gamma goes down and beta goes up, you don't make enough beta, you get less hemoglobin A, and the leftover alpha chains are incredibly unstable, so they can't be used to screen. So it's this low hemoglobin A that's a marker of beta thalassemia. So normally in the newborn period, you have a lot more F than A. In beta plus thalassemia, you make some hemoglobin A, but it's even further diminished. And in beta zero thalassemia, you don't make any hemoglobin A. So all you see on newborn screening is HbF. So what do these chains do when they're in balance? Chain imbalance leads to anemia that leads to growth abnormalities and organ dysfunction. With severe anemia, patients are often transfused, which lead to iron overload. And then this leads to iron overload in liver, heart, causing dysfunction there. Endocrine organs in the pancreas, it can lead to diabetes, overload in the pituitary and gonads. It also leads to ineffective erythropoiesis, which worsens the anemia. So your body tries to make more red cells, which increases the amount of ineffective erythropoiesis, which also leads to inappropriate iron uptake, which increases iron overload, even if you're not transfused, worsening these problems. It also leads to expansion of the marrow space, leading to bone disease and problems there. It leads to extramedullary erythropoiesis, leading to hepatosplenomegaly and pseudotumors along the spine. It can lead to microparticles that are both emboli, and this leads to both hypercoagulation and vascular disease. And it leads to hemolysis, which leads to more microparticles and anemia and gallstones. And so the impact is highly variable depending on what form of thalassemia you have, from a carrier state to a mild anemia to being transfusion dependent. And it can have a tremendous impact on organ function and need close clinical monitoring. And again, there's huge genetic counseling implications. So there's big reasons to diagnose early. And this is my last slide before handing it over to Patrick, but it's complex. So the alpha thalassemias, usually it's deletions of the alpha genes, and as you delete more alpha genes, you have more severity. If you delete only one alpha gene, you're a silent carrier. These patients are normally hematologically normal. Often you can't tell by looking at a routine CBC. And it's just about genetic counseling. If you delete two, you have alpha thal trait, where you have a microcytic anemia. Patients are often inappropriately given iron, thinking they're iron deficient, but really it's a big genetic counseling issue. When you delete 3 or 4, these are the forms that are most clinically significant. Deleting 3 forms leads to hemoglobin H, which needs to be monitored, and these patients sometimes need transfusions, but they should be followed. And the most severe is without any alpha. This leads to hydrops fetalis, which is usually leads to fetal demise and can be incredibly toxic and even lethal to the mom. So it's really important to detect and try to avoid. As you delete more alpha genes, the amount of BARTs goes up. And these numbers vary depending on the testing procedure. But you delete more alpha genes, you have more clinical severity, more hemoglobin BARTs. For beta-thalassemia, you have two types of genes. Beta-0 mutations, which kill expression of the gene, and beta-plus, where you have decreased expression. And here, these are the more clinically significant forms. Thal major, these patients are dependent on transfusions from early life, needed for survival. Thal intermediate is more complex. You don't necessarily need transfusions for survival, but transfusions often significantly improve the health of patients. So all these patients really need to be hooked up for care. And a trait, again, it's genetic counseling. So the big question for newborn screening diagnostics is, what should states do? Should you do a qualitative test? So for alpha thalassemia, just report out BARTs is present, which says you're somewhere in this box, anywhere from a silent carrier to this very profound state or hemoglobin H. So it can be sensitive, but not specific for the form. Or do you just ask for, is F present? If hemoglobin A is present. Some people report out absence of detectable hemoglobin A, which means it's a thalassemia major, but that's not going to be very sensitive because it will often miss some thalassemia intermediates. Or do you do something more quantitative? And now it gets tricky. Do you just say low, medium, and high BARTs? Or decreased A? Or do you give numbers and quantitation, like a specific percentage, to try to narrow things down specifically? And so there's a lot of questions about this. But before going into that, I'm going to hand over to Patrick to talk about testing.
Thank you, Dr. Bender, and thank you all for joining us on this webinar. So, what I'm going to do is I'm going to provide you with a brief overview of how we detect alpha and beta thalassemia on the newborn screen from the dry blood spot. Okay, my slides aren't advancing.
Try clicking on the slide and using your arrow keys.
There we go.
There you go.
I'm sorry. Okay, and this is a funding acknowledgement for me. And so the main testing methods that are used in the hemoglobin screening laboratories are isoelectric focusing, Hplc, and some states are utilizing molecular. So isoelectric focusing, or IEF, is agarose electrophoresis and a pH gradient, which separates the hemoglobin fractions according to their isoelectric point, or the pH at which their net charge is 0, forming concentrated hemoglobin bands. So the hemoglobin fractions migrate across the gel, changing their charge as they go through the zones, and then they stop when they have a charge of 0, and kind of pile up and concentrate. So this is a really good method. High performance liquid chromatography, or HPLC, uses pumps to pass pressurized liquid solvents containing the sample through a column. Hemoglobin fractions stick to the column and are released gradually depending on their charge, and then are measured via UV light absorption as they pass through the detector. And then the various molecular methods are various DNA methods such as mutation analysis, sequencing, and real-time PCR allelic discrimination. And all these are used for the last tier only. So this is a breakdown of the strategies that states use. So they can use 1, 2, or all 3 of these methods. There's 20 states that screen every baby with IEF and then use HPLC as a second tier for the ones that are abnormal or questionable. 10 states only use HPLC. 7 states use HPLC then IEF. 4 IEF then DNA. 3 states only IEF. 2 use IEF, then HPLC, and then DNA, and finally 1 HPLC, and then DNA. And I got this data from the New Steps data resources on methodologies. So isoelectric focusing is still, the gels are still plated manually, as you can see here, and we can plate 10 samples at a time with a multi-channel pipette. IEF was the first multiplex assay in newborn screening, and it was really kind of a disrupting technology when it came out in the late 1980s. But it's a wonderful technology, and it detected, it detects several hemoglobinopathies along with the corresponding carrier forms for everything except for beta-thal. We cannot detect beta-thal carriers, but we find the carriers for all the other things that that show up on this method. And so that was kind of disruptive in the way, because our intention wasn't to find carriers in newborn screening, but in this case, it's there. We have to report them. This method has very few false positives and very few false negatives, and it has not changed in over 30 years. So this is what the gels look like after they're plated. Each gel can hold 60 newborn screening samples and 6 controls, although some states use smaller templates and can get as many as 80 newborns on a gel. Notice that all the samples are to the right of their well numbers. After electrophoresis begins, both sides will start moving to their anodes. So I'm going to give you a little time-lapse photo series here. This is after 20 minutes, and you can see both sides are moving towards the anodes, to the right and to the left. After 40 minutes, on the left side, you can see there a positive BARTS is starting to focus in the fast region. So like Dr. Bender said, BARTS is the hallmark for alpha thalassemia. After 60 minutes, more BARTS bands are starting to show up on the left side. And then the fetal hemoglobin bands are starting to focus. Hemoglobin F and acetylated F, which are the predominant bands, because newborns are born with about 70 to 80% fetal hemoglobin if they're at the normal gestational age. After 80 minutes, the adult hemoglobin A bands are starting to focus on each of the samples, and that's the middle of the 3 predominant bands, with the fetal and the acetylated fetal on either side. So now on the right side, you can see the 3 samples here that have don't show any hemoglobin A at this point. So that's a sign that a beta-thalassemia is going on, or a double heterozygous beta-thalassemia. After 110 minutes, 110 minutes, focusing is virtually complete, and the power is shut off at 120 minutes. And then the gels are fixed with solution to lock the bands in place so they don't diffuse back out. And so everything is nicely focused and ready to be stained and dried. So that's the last step. And so after they're stained and dried, they're much darker and easier to be read. And so you see that there's actually 4 BARTs on the left side, one that is just barely above the with 2 visible bands and reportable, and then the other 3 moderate and highly elevated levels. So there's on the right side is a sickle beta plus thal and an E beta plus thal, and then the F only, or the beta thal major that Dr. Bender was talking about. And so we also use these ratios here to decide if they're the ratios remarkable enough to report as a disease condition and refer to a hematologist. So the HPLC screening method, this is the one that the majority of the states are using. And here's the auto sampler and the solvents that go through, and then the column and the detector are in this box here. And so you get, with these, you get chromatogram reports that show the peaks and actually quantitate the hemoglobins, or give pseudo quantitations that you can make decisions on the risk. And on this one, the BARTS is the very first peak that comes off, and this has an elevated, has a BARTS that is moderately elevated, and they show up in the chart above here with all the percentage of the other hemoglobins. This is a chromatogram Hplc printout of a beta-thalassemia result that only has 0.8% hemoglobin A. And remember, the normal baby has about 20 or 30 or 40 sometimes. And so this is almost below the detectable limit. Probably wasn't even visible on the IEF gel, but nevertheless, this is very low and is probably a double heterozygous beta-thalassemia. So there's great diversity among states in their newborn screening lab report, verbiage, contents, and follow-up, as Dr. Bender noted. And so most states will notify the primary care physician of the presumptive positive results for a alpha or beta thalassemia presumptive positive disease condition by phoning and faxing the result to the physician of record. And then there's various other combinations of things that take place at that point, like a direct phone call from the state's follow-up team for the next steps needed, or letters are sent describing the screening result in more detail and stating that the baby should be referred to hematology for confirmation, additional confirmatory testing, additional educational materials such as ACT sheets or state-specific materials, and then specialty care centers provide the family with education and counseling regarding the condition. So I'm going to give you just lastly 4 state examples of what the screening result comment would look like to show you the variation. And I'm only going to do it for the highly elevated BARTs or the hemoglobin, presumptive positive hemoglobin H. And so this is New York's, and I've highlighted in red kind of the main points of what they say, and there's kind of a common thread between all states of what is said in these, but some say more than others. This is Michigan's. They have a little different format of how they do it, but basically says the same thing: positive hemoglobinopathy screen with BARTs, and a blood spot has been sent to a reference laboratory to complete the testing. This is the state of Washington. More explanation and verbiage made available, but also kind of the same message: positive hemoglobinopathy disease, hemoglobin H disease, significant risk for hemoglobin H disease, and results should be confirmed as part of a diagnostic evaluation. And then this is Missouri's, which is even more wordy, but this was all approved by our hemoglobinopathy advisory committee to get as much information in there as we could up front. And so, but it also says possible hemoglobin H disease, highly elevated BARTs, further clinical tests are needed, and all the other stuff is provided. So that's just an example. And now I'm going to turn it back over to Dr. Bender.
Well, thank you, Patrick. And I just really love looking at the gels, and I hope you reflect how, at least for me, especially for the beta thalassemias, how difficult it is going from looking at those gels to making a diagnosis. So what do you need to know? And I'll cover this, but the bottom line is newborn screening for thalassemia in the United States is highly variable in terms of the method, in terms of the quantitation, what conditions are reported out, and who's notified. And so the important thing for you is, please, you need to understand what your state does. So the Association of Public Health Laboratories, the hemoglobinopathy group, wondered, what do various states do? So they did several surveys, sent it out to all US newborn screening programs, got very high response rates of 80 to 90%. And as Patrick mentioned, all programs used isoelectric focusing, or Hplc, platforms that are capable of detecting severe alpha and beta thalassemias. The implication is severe forms of alpha and beta thalassemia can be picked up by all programs in the United States using the currently used platforms used for sickle cell screening. So everyone has the potential to refer possible severe thalassemia for follow-up and specialty care. But thalassemias are not on the list of recommended disorders for newborn screening, right? But despite it not being on the list of recommended disorders, most states report out at least one form of thalassemia. About 83% report out at least one form of beta thalassemia, and about 93% some form of alpha thalassemia. So the landscape we're dealing with in the United States is that not all states are reporting out potentially severe thalassemia, and what and how they report out varies dramatically. So there's high variation in how qualitative versus quantitative the states are. And the letters Patrick showed reflect this. Some just saying, like it says, Bart's is present, right? Or others will say just no hemoglobin A is detected, while others will base it on and report out, as in the letters, the exact percentage of Bart's or the percent of hemoglobin A or the A to F ratio. There's a high variation in what forms of suspected thalassemia states report out. So about half the states report out and call out, we think this is a hemoglobin H, which is clinically significant. And about 20% call out a suspected silent carrier, which is benign except for genetic counseling issues. So a lot of variation. And then there's variation in the thresholds that are used for defining the disease forms. And it's not surprising there's variation in the thresholds because people are using different platforms. So for hemoglobin H, the minimum range is 11 to a max of 31 Barts, and they call it hemoglobin H disease, etc. The important thing for you to be aware of is, let's say you've got a consult on a child that had 11% Barts at birth. In one state, that child would be thought to have hemoglobin H disease. In another state, that child would be called thal trait. And in another state, it would be called a silent alpha thal. So it's confusing. So the state a child is born in determines if a potentially severe thalassemia is reported out and what forms of suspected thalassemia are reported out. So alpha thal trait, again, mostly a genetic counseling issue. Sometimes given inappropriate iron, need to, sort out that versus iron deficiency, but no severe clinical issues in some states. But in other states, a more severe condition, hemoglobin H, is not even reported out, right? Despite it being more severe. In terms of who is notified, there's variations to whether it's the provider, the family, or both that are notified. And the recommendations for lab work, genetic counseling, and who and where to refer vary between states. And some people, when they responded to the survey, stated that they did not have specific recommendations for follow-up. So the state a child is born in, again, determines if a potential thalassemia is reported, how detailed the report is, who's notified, and the follow-up. And the implications are an infant with a potential severe form like hemoglobin H or thal intermedia may be referred for evaluation in one state, but not a neighboring state. So put another way, a clinically significant thalassemia is not always reported. So a normal report, depending on the state, does not exclude a thalassemia. So again, depending on the state, if a thalassemia is not reported out, you cannot always assume the infant is free from thalassemia. So to me, this is a national health inequity, right? Who gets efficiently referred to specialty care at birth, and what infants develop failure to thrive, have multiple evaluations, given courses of iron before a diagnosis is made. What family is referred for genetic counseling, and who ends up having a hydropic pregnancy that could have been prevented or treated if there was adequate genetic counseling beforehand. And so there's opportunities to decrease these inequities and increase public health information. One approach is to increase harmonization in terms of what's reported out, how, and to whom thalassemias are reported in terms of reporting high, moderate, low BARTs or percentages. And reporting out would, to me, would be helped if people use the same language, right? With one state just saying BARTs is present or no hemoglobin A, someone saying decreased hemoglobin A or BARTs, to come up with a common language which would allow for uniform mapping and tracking and targeting across the country so that everyone was speaking the same language and you could compare, which would help improve incidence, prevalence, and location data, and also help better target resources so we know where patients are and can provide support. So what about actions, okay? For providers, the big thing is make sure you understand what is reported out in the state, and critically, what is not reported out. And you need to know how to interpret results. For example, if you're told there was 11% BARTs, you need to know for that specific state what that correlates with and if that test was validated. And then you need to make sure your guidance and approach to diagnostics is then fitting with this in terms of whether you use secondary screening or definitive testing with isoelectric focusing, capillary electrophoresis, Hplc, CBC, retic, looking at inclusion bodies, looking for alpha thal, iron studies, or DNA testing. It's going to depend on sort of what you're handed off. And if the child's from another state, you need to make sure what that state does for their testing. So what to do? And the ask for you all is think about what resources would help you and speak up. The Cooley's Anemia Foundation and the CDC want to help, but how? What would help you? Do you want algorithms in terms of what to do with newborn screening results? Do you want webinars, checklists, family education materials, or other resources? Let people know. For providers, if you're looking for a source to help interpret newborn screening results, I'd say first, some states have a hematology consultant. So reach out to them. They work with the newborn screening program and should be able to help you out. Otherwise, reach out to the Cooley's Anemia Foundation. They will connect you with a thalassemia expert. For families, if you're looking for resources, the Cooley's Anemia Foundation is fantastic about hooking people up with information, education, hosting events, and connecting you with expert care. And if you've got ideas for new resources, reach out to the Cooley's Anemia Foundation or the CDC. And then finally, what are people talking about, these days regarding newborn screening for thalassemias? So one question is whether to push for a first-tier listing for the recommended universal screening panel. This is the group finally certified by the Department of Health and Human Services that says, yes, this condition should be screened for. Do you push for that for thalassemias? Notably, most states are already doing it, but it could still be helpful. Do you push for harmonization? And to what extent? In terms of a numeric quantitation or high, medium, low? Is there enthusiasm for providers, hematologists by the newborn screening programs? And what's that going to do to cost? I think there's a need for improved public health and surveillance data. Increased harmonization would help that, but this costs money, as do longitudinal studies, which, we don't have great longitudinal studies or natural history studies in the United States of what happens with newborns diagnosed with thalassemia. And finally, of course, everyone's talking about molecular testing, especially next generation testing. This could be a great way, especially for diagnosing thalassemias with the many types of mutation. But then there's many different platforms. Some states are good at it. Some states don't have it at all. And so again, it comes back to a question of equitable access and then harmonization. When you get results back from sequencing, it is incredibly complex. And how do you interpret it the same way amongst different states and platforms? So it brings up lots of questions. So with that, thank you for your time, and going to open things up for questions.
Thank you so very much, Patrick and Bender. Always insightful, always clearly presented, and an important perspective offered by both of you in each of these areas. We're going to move now to the question and answer period. There's a couple of questions in different sorts of groups. So the first one, Patrick, we're going to go to some technical aspects. One of our viewers is interested in whether or not there's a way to introduce automation to the interpretation of the gels, in particular IEF. You know, kind of casting that human eye, is there a way to eliminate some variability in interpretation? What are your thoughts about that technique in particular, and how things might be able to go on the laboratory side?
Sure. Yeah, there is a vendor that's that has or is coming out with or already has plate readers that you can have them read the gels after you make go through a certain procedure, and have them read the gels. And I think it might even quantitate the bands. I'm not sure, but yeah, there is a little bit of automation there in the reading part. I think there's some states, I know there's some states that have the automated auto samplers that actually plate the gels. And I think, I don't want to call it, but I know there's some states that have those. You got to kind of keep an eye on them though sometimes, but they do have automation in that aspect.
A follow-up question is, given that there's we've heard about thresholds for a certain percentage of A present or not that might trigger advice about maybe there's a beta-thalassemia present. Are those automatic readers sensitive enough to pick up the small differences we might advocate? Where are we at with that technology?
I don't know about that. I would think that the states would lean more on their Hplc to get those percentages of A and the ratios of A to S or C or E. But I'm not really sure the plate readers. I haven't seen them in action, so I don't know if they just flag up something that's low or how that works. But the Hplc gives nice percentages that we use in-house. We don't usually put those percentages on the lab report, but sometimes they're conveyed to the specialist when when it's reported out to the specialist.
Okay, thank you. A second technical aspect, I think both Patrick and Bender, you'll have commentary and perspective on this, is one of our colleagues in California, Long, in the thalassemia community with a lot of expertise, is pointing out that these protein analyses don't always pick up the non-deletional mutations, unstable alpha-globin variants. I mean, we are working with proteins and trying to infer complicated genetics, right? So do you guys have a perspective on some of the variations? Thalassemia, even as straightforward as you made it, Bender, is not that straightforward.
Right, and I'm sorry, with the time constraints of the seminar, it's hard to cover everything. And one of the biggest concerns is the most clinically significant forms of hemoglobin H disease are ones where there's actually a mutation that's not a deletion of an alpha gene, a non-deletion alpha thal. And those tend to be the more clinically severe forms and not readily picked up. For that, ideally, it's DNA testing, and each state does something differently. So in Washington State, we do for everyone with hemoglobin H an allele-specific PCR looking specifically for one of those mutations, constant spring, but we don't look at other non-deletion mutations. Other states do a little more extensive sequencing. Most states don't do anything and it'll be missed. So when thinking about harmonization in the future and molecular testing, I think these are key critical questions. And I think this is one argument for more universal DNA testing.
Patrick, some comments about that from the public health laboratory perspective?
I think Dr. Bender covered it very well. I think we can pick up that highly elevated BARTs. in the case of hemoglobin H constant springs, it still shows a BARTS, but there's, like you said, there's some other variants that may not be picked up as easily. I don't know how common those are, but I think Dr. Bender addressed it very well.
All right, thank you. So moving a bit from directly in the laboratory, but pertinent. So Patrick, first to you. So it's pointed out that sometimes immigrants and refugees will come to this country, and it's easy to get a dried blood spot, and perhaps a state lab would accommodate testing of perhaps older children or even adults. What's the reliability of using this if that's available in your state public health laboratory in terms of test results?
Well, and we do get those with adopted babies and immigrants and people that move from other state where they're not necessarily sure what the original newborn screen was or if there even was one. But it does kind of depend on how old the baby is or the child. You miss that window of opportunity to get measured BARTS because it does go away with the fetal hemoglobin eventually. So that's a big issue with older babies for alpha thalassemia. But for beta thalassemia, it can be detected maybe even easier, and so and more precisely in older children. So in some states they have limits on what they'll test as far as age. We don't in Missouri. So there's another state to state variation on how old of a baby they will test actually a dry blood spot.
Awesome. Bender, any other thoughts from your experience in the Pacific Northwest? Or?
No, I think Patrick hit it. The big things are some newborn screenings will test non-newborns, others will not. And that the older a child gets, the less you can rely on looking for hemoglobin BARTS, and you have to move to other testing, which newborn screening programs typically are not set up for. And in contrast with beta thalassemia, as Patrick shared, it actually is easier screening and picking up in older patients as opposed to newborn.
Okay, thank you. While we're talking about the dried blood spots, there's a question about what states might be doing when they say they do DNA. Are they doing it on the dried blood spot, or are they actually doing it on another sample from the baby? And I'm sure it's highly variable, but can you give us a sense of that, either of you? So they're using the blood spots to do the DNA?
So typically it is off of the dried blood spot. Some states then will refer, and then it's the person or lab they refer to may do an actual blood draw, but often it's off of the dried blood spot.
Okay. All right, thank you. There's a question about some specific results. For example, one of our participants is interested in the evaluation of hemoglobin FEA as a newborn screening result, or of FE. What would you recommend in that sense, both from a public health and perhaps a clinical perspective?
Yeah, I'd like to focus more on FE because this is another issue that varies between states. So for those of you that don't know, when states report out results, they report out hemoglobins in the order of prevalence. So normally be FA, mostly fetal, and A. Sickle cell trait would be FAS because you have more A than S in sickle cell trait. So the question is, what's the diagnosis if it's FE? So FE, if all you see is fetal hemoglobin and hemoglobin E, there's two possibilities. E is an abnormality of a beta chain. So either that patient could be homozygous for hemoglobin E, so FEE with two copies of the E, which is a hemolytic disease, should be followed but not particularly severe all the time. Or it could be hemoglobin E with a beta-thalassemia. That is a highly variable genotype, and many of those kids need to be transfused chronically. So sorting out if there's one E there or two E's is really important. And many states don't address it. You know, in Washington state, we do an allele-specific PCR looking for a normal allele to see if there's an E allele and a normal allele, although that's not perfect easy either because it can miss some deletions. So it is very complex, and this is one reason you need to talk with your screening program in terms of what they report out. If they're doing a test to distinguish FEE from FE thalassemia. And it's the same thing with hemoglobin C or any of the variants where there's no hemoglobin A.
All right, Patrick, any thoughts from the public health laboratory perspective, reporting results, et cetera, recommending follow-up?
Well, and Dr. Bender said it very well. And when we get an FE, we even say in the comment, hemoglobin, homozygous hemoglobin E or E beta thalassemia, we don't know. And so that has to be, you know, figured out through confirmatory testing and DNA testing, parent testing and other things. And so, you know, if we do see a small amount of hemoglobin E, then we know that there's a double heterozygous condition going on. And so it may depend on how much A that baby ends up with, how much normal hemoglobin A to the severity of their disease. But it just because there's no hemoglobin A visible on the screen doesn't mean that there's not ever going to be some. Sometimes it's just such small amount that it's not caught, it's not visible to the naked eye, and the HPLC, it may not detect it either. The state may not be using an HPLC. So.
Okay. Along those lines, oops, sorry, Bender, go ahead.
Just following up, I think people need to be clear. This is newborn screening. That doesn't mean definitive testing. So there's a handoff from newborn screening to someone else that is typically responsible. But again, what that handoff looks like and how much evaluation is done by the state lab versus outside the state lab varies depending on state.
Along those lines, just to perhaps emphasize the point as an opportunity, one of our participants noted that, you know what, hemoglobin H disease, maybe even an alpha thal trait, hemoglobin A2 is often lower, right? Alphas are a part of that as well. I wondered what your perspective is about the opportunity about recognizing a low A2 as a diagnostic maneuver, or more importantly, the A2 is normal, therefore it can't be an alpha thal. And is that an appropriate way to think about things in the context of newborn screening, or does that come later in more definitive testing, if at all?
I'll go first. The hemoglobin A2 is not even detectable sometimes in newborns. So I don't think that would be a good way to hang your hat on alpha thalassemia detection at all. Whether it's always, if it's there, it's always in its infancy anyway, the hemoglobin A2, when we see it as a one-day-old baby. So yeah, there are babies that are born with A2s, but they're already decreased. They're still growing in concentration as the baby gets older.
Mm-hmm. Okay.
And in addition, I agree completely. Going back to the gels that were shown, some states do HPLC, so you get a number. But if you remember, there are some bands you could barely see on the gel that were only picked up by HPLC. So, and some states, they don't do HPLC. It's just, you know, it varies. Some scan the isoelectric focusing gels. Some states, they report, they just look by eye. They leave it at that. So again, it's going to be state dependent, and you need to know what your state does.
All right, awesome. Thank you, guys. So there's a small cluster of questions to step a little bit into the bigger picture, especially as you've introduced to us, Bender. So it seems like there's an opportunity, persons are commenting about understanding the epidemiology in this area of thalassemias and newborn screening, centralize a national database, maybe that can help drive, standardization and testing. So can you give us a sense of the landscape of perhaps efforts underway or that you'd like to see in the realm of newborn screening, using this to understand the epidemiology of things like thalassemia and feeding back and in turn perhaps creating the impetus to be more consistent? So your guys' thoughts would be appreciated.
Yeah, that's a huge question. I love it and would also appreciate your input, Kathy. So the tough thing is, how do you pull people together here, right? That the problem, and this gets to be a much bigger issue, because to get on the first tier of testing, you really need definitive data that early detection in a newborn changes morbidity and mortality in children under 5. And while providers tend to think that's a great idea, there isn't great data in the United States that newborn screening, makes that difference. So one is looking at that, looking for that. But then the other thing is, the state labs say we need to hear from the hematology community. So one approach is to pull together the hematologists together and say, this is what we really need to better serve our populations, and then reach out to the newborn screening groups as a whole in terms of pushing for harmonization and better data collection.
Mm-hmm. And Patrick, the public lab, because Bender reflected that, the public lab perspective on that, it's easy for us as clinicians to say, you got to do this, but it's another thing to actually implement and try and harmonize across state systems.
That's very true, and it's very hard to do between states, and so I would just say, Dr. Bender really addressed it really well. Just good communications between the state programs and their hemoglobinopathy advisory committees on what their goals are and what they can do, as far as the screening test goes.
Okay. We're coming near the top of the hour, but there's a couple of things that I wanted our speakers to hear are being asked about and to give a short opportunity to answer. One is, given that there are perceived ethnic distributions for some of these disorders, can you guys comment on the validity either in the state lab basis or clinically, Bender, about using an apparent race or ethnicity sort of algorithmic approach to some of this testing? Cut costs, let's just do a targeted screening, if you will. I'd be interested in your perspectives on that.
Short answer, no. And, it is for multiple reasons, okay? You just can't look at someone or hear about their origin and say, what's going on. And it really needs to be universal. With everyone gets the same screening and is treated the same way here, and then gets the same follow-up.
And Patrick, I think your perspective is important, again, from the public health laboratory. Do most states have an opportunity in the public health lab setting to really start making those almost clinically oriented decisions? Is that easily done or feasible? Even if it were a valid sort of thing?
No, I totally agree with Dr. Bender. It's just it's best to treat every baby equally and test them equally. And I know we some states don't even collect race or ethnicity on their card. And so, yeah, I totally agree with Dr. Bender.
Awesome. Well, I think there's a couple of requests for some information that I think our organizers today will support. One is, Bender, you really intrigued some interest with the in utero transplantation discussion, and they'd be interested in seeing different references or sort of somewhere they can go to learn more about that. And I think we can accommodate that certainly in follow-up to the webinar. And the other thing, there was an interest in the survey that was conducted by this working group of APHL. How many states are actually doing DNA, you know, which states? And I think to the extent that we're able, we'll try and get that information shared as part of a follow-up on this webinar. And I think as I see the time is upon us and we've gone through most of the questions, I wanted to just thank Bender and Patrick for all this valuable information about the newborn screening for thalassemia. It's complicated, but you made it really understandable and really enjoyable to learn about. I also want to thank our colleagues at the CDC Division of Blood Disorders for the invitation to be with you today, and to the Cooley's Anemia Foundation, a shout out to them. They're hosting this webinar. Thank you very much. Very shortly, you're going to receive an email asking for your feedback, so please respond with your comments. We take them seriously. We'd love to understand how things can be better. If you have additional questions, you can see Cindy Sayers' email there available for you, and please reach out through that or any other contact information you may have received with the invitation to the webinar. As noted, this webinar will be archived and the content should soon be available at the CDC's Division of Blood Disorders website. So please visit there if you'd like to revisit this and/or please share amongst your colleagues. We are hoping to disseminate this really valuable information to as many people as possible. Thank you so much for joining, and I hope the rest of your day or your evening or your morning, wherever you're at, it goes well and is successful. Thank you very much for coming today.
Thanks, Kathy. Thanks, everybody.